The Colles lecture is the most prestigious lecture of the calendar of the Royal College of Surgeons in Ireland, commemorating Abraham Colles, described as the most outstanding Irish surgeon of the 19th century by Professor Davis Coakley in his book Irish Masters of Medicine. Students around the world are familiar with the fracture of the distal radius that bears his name. Perhaps fewer appreciate his description of fascia in the perineum and a ligament in the inguinal area that also bear his name. Colles was Professor of Anatomy, Physiology and Surgery in the college. Our lecturer today, Professor James Lau, is Chairman of the Department of Surgery and the Yaoling Sun Professor of Surgery at the Chinese University of Hong Kong. He graduated in medicine from the University of New South Wales, Australia in 1987 and obtained his MD degree from the Chinese University of Hong Kong in 2001. He holds fellowship of the Edinburgh and Glasgow colleges and the College of Surgeons of Hong Kong. Professor Lau is a trained vascular surgeon. However, his major research interest is advanced endoscopy, particularly in the management of upper GI hemorrhage. His seminal research on endoscopic treatment has transformed surgical practice. I can still remember his presentation to the International Surgical Group when we visited the Prince of Wales Hospital in Sha Tin many years ago. And I know we are in for a memorable 96th Abraham Colles lecture on the demise of emergency ulcer surgery. Professor Lau.
I'd like to thank Professor O'Connell and the Royal College for giving me the honor of the 96th Abraham Colles lecture. The Prince of Wales Hospital is known for its clinical trials in the management of acute upper gastrointestinal bleeding. The hospital is a teaching hospital to the Chinese University located in the New Territories, and it opened in 1982. The Faculty of Medicine at the Chinese University was inaugurated at the same time. This year we are celebrating our 40th anniversary. As a medical school, we also rank in the top 40s in the world. Here's a picture of our founding dean, Dr. Gerald Choi, and an advisory group from the United Kingdom. Professor Arthur Lee was the founding chair to surgery. He graduated from the Cambridge University and was a consultant to the Royal Free Hospital in London. The founding chiefs to endoscopy were Professor Sidney Chung and Professor Joseph Leung. Professor Sidney Chung was a graduate from the Trinity College in Ireland, and Professor Leung had just learned ERCP from Professor Peter Cotton at the Middlesex Hospital, London. Therapeutic endoscopy was just about to take off in the 1980s. One of the pioneers was Professor Nip Suhendra from Eppendorf Hospital, Hamburg. He was the first to report injection therapy to bleeding ulcers in 1977. The Prince of Wales Hospital was credited with the world's first RCT to show that adrenaline injection reduces the need for surgery. The study was published in the British Medical Journal. It was the first study to many randomized control studies from our hospital in the management of patients with acute bleeding. In the 1990s, our research focused on how best to improve results with adrenaline injection, and one strategy was to add a second treatment following hemostasis with adrenaline. In this forest plot, we can see all the dots going to the left, favoring the use of combined treatment. In this pool analysis of many randomized control studies, combined therapy is shown to reduce not only recurrent bleeding, surgery, and importantly reduce mortality by approximately 50%. And nowadays, the standard therapy is either the use of a thermal contact device, as shown in this video, or the use of hemoclips. Contact thermal device has stood the test of time and has been around for over 30 years. Another commonly used device is hemoclips. And nowadays, of course, we have many modifications of the hemoclips in the market. Clips and thermal devices are considered the current standard, and in this meta-analysis of comparative studies of clips to thermal coagulation, the two modalities are actually comparable in their hemostatic efficacies with a pulse-out ratio of 1. The game changer in the management of ulcer disease was the discovery by Barry Marshall in the 80s. He ingested what was then known as the Campylobacter pylori. He then underwent endoscopy 10 days later to find acute enterogastritis. He postulated that infection with H. pylori would lead to ulcer disease. And we all know that Barry Marshall subsequently received a Nobel Prize for his discovery. And it took the medical community many years to be convinced. Our group was amongst the first to use antibacterial therapy to treat ulcer disease. Sholin Hodgkin was a fellow from the United Kingdom to the department, and he published a study in Lancet in duodenal ulcers, or H. pylori associated duodenal ulcer. And Joseph Song published a similar study in the New England Journal of Medicine in the following year in patients with HP associated gastric ulcers. And the two studies show that healing in both duodenal and gastric ulcers were similar in patients given triple therapy or antibacterial therapy alone without exit suppression. The findings provided evidence to support the etiologic role of H. pylori to hepatic ulcer disease. The two studies show that healing in both duodenal and gastric ulcers were similar in patients given triple therapy alone without exit suppression. The findings provided evidence to support the etiologic role of H. pylori to hepatic ulcer disease. More importantly, the eradication of H. pylori leads to cure of ulcers, and ulcer disease then no longer considered an intractable disease. I joined the Chinese University in 1992. The first clinical study that I planned was the RCT that compared further endoscopic treatment to surgery in patients who develop recurrent bleeding after initial endoscopic hemostasis. The surgical dogma in the 1990s was to operate at the first sign of recurrent bleeding, and surgery was considered the most definitive in stopping bleeding. In this clinical trial, we committed all patients with bleeding ulcers to the same treatment protocol and waited for them to rebleed. Of more than 1,000 patients treated uniformly with heated probe treatment, we enrolled only 92 patients into an RCT over 5 years. Our endpoint was the control of bleeding within 30 days, and in this clinical trial, we showed that in about 3/4 of the patients, further endoscopic treatment would lead to control of bleeding over 30 days. We also show that further endoscopic treatment in intensive to treat analysis was associated with less complications and did not increase mortality. And findings from this RCT encourage us to persist with endoscopic treatment in those with recurrent bleeding, and the rate of emergency ulcer surgery for bleeding declined steadily over the years. My second planned RCT was on exit suppression, and the rationale for exit suppression was based on an ex vivo study in which platelet aggregation was titrated against plasma pH. In neutrality, clots will be very stable with platelet aggregation approaching 100%. And on the right, you can see intragastric pH profile in patients given a high dose infusion of PPI. With a high dose infusion, the intragastric pH can be kept consistently above 6. The concept of a high dose PPI in fact originated from the AstraZeneca company, and they had commissioned Scandinavian countries in conducting 2 very large randomized control studies, and these were placebo-controlled studies. These studies were published in the Scandinavian journals, and unfortunately, the efficacy endpoint to these studies were a little difficult to understand, as highlighted here. I had the opportunity to listen to the presentations at the Digestive Disease Week, and I came home and decided that I could simplify its design. And I contacted our own School of Pharmacy and did our own placebo-controlled study. And in this RCT, we enroll only the highest risk patients and those with actively bleeding ulcers or an ulcer with a large vessel at the ulcer base. We treated this ulcer with heated probe treatment, and after endoscopic hemostasis, we randomized them to receive a high-dose infusion with PPI or its equivalent placebo. And we followed them up for 30 days, and the primary outcome endpoint was freedom from further bleeding, and that we showed that PPI infusion in fact led to an almost 5-fold decrease in recurrent bleeding from 22% to around 7%. And we were very fortunate again to publish it in the New England Journal of Medicine. There were, of course, controversies over the need of a high dose or whether a low dose would also work, and whether PPI can be given orally or intravenously. The study, however, provided conclusive evidence that acid suppression is important as an adjunctive therapy in the very high-risk bleeding peptic ulcers. Following the publication in year 2000, proton pump inhibitor was increasingly prescribed, and often with the wrong indication and before an endoscopy was performed. The question begging to be answered was the impact of PPI infusion in those waiting to be scoped. Then we planned the next clinical trial using PPI before endoscopy, and we enrolled about 600 patients in this RCT. And these patients were randomized to receive a PPI infusion or a placebo before endoscopy in a mean of about 12 hours. In our cohort of patients, about 60% had bleeding peptic ulcers. We showed that prior PPI use had a clot stabilizing effect. And on endoscopy, there were fewer patients with active bleeding given prior PPI, and that PPI also downstaged the stigmata of bleeding in ulcers. And there were significantly more ulcers with clean base giving PPI. And in clinical practice, this translates into reduced endoscopic therapy in patients given PPI, and the patients were able to be discharged earlier because of the clean base ulcers, and translating into cost saving to the hospital. And here I show a video of a patient with a difficult to treat ulcer, and you can see clips falling off, and eventually we stop bleeding with the use of heat probe, and the vessel measured about 3 millimeters in size, and this is a very large bulbar duodenal ulcer. And we know that if the patient will bleed again, the mortality increases by about 3-fold. And in this patient, we offer added angiographic embolization following endoscopic hemostasis. And you can see coils in the proximal and distal duodenal artery with gel forms in between. And the patient did well without further bleeding. In an RCT published in 2019, we tested the hypothesis that in high-risk patients with bleeding ulcers after endoscopic control, added angiographic embolization would reduce bleeding and improve outcome. The figure belongs to a post-hoc analysis, and we divided patients into two groups. And patients with ulcers 50 millimeter or more without angiographic embolization had a rate of recurrent bleeding of about 23%, trove in 52 patients, compared to patients, 44 patients in whom added angiographic embolization was performed, and the rate of recurrent bleeding was only 4%, with a hazard ratio of 5.4. And the number needed to treat was approximately 5, indicating that you really only need to treat 5 patients to prevent 1 recurrent bleeding. And following this study, we are now more liberal in offering angiographic embolization in patients with large ulcers with the view to prevent recurrent bleeding. And in the last 10 years or so, we been working on novel endoscopic therapy. And one of the novel treatment is hemospray, which is a mineral blend powder, specifically is made of aluminum silicate. And we published the first clinical trial in 20 patients actively bleeding ulcers, and in 19 of them we were able to stop bleeding. And the powder was originally approved for use in stopping external bleeding from external wounds in both civilian and military injuries. Here's a video of how the powder would work. And this belonged to a patient in whom we try heatable therapy, and we found it very difficult to control bleeding. And we decided then to use hemospray, and you can see 3.2 millimeter catheter with the powder power driven using a carbon dioxide canister. And without going into details, our group is publishing a randomized control study to show that the powder is not inferior to standard therapy in the control of bleeding from non-variceal upper GI bleeding. And it is particularly good in tumor bleeding and bleeding from diffuse source. Another novel treatment is the use of OTSC, or over-the-scope clip. We contributed to this multi-center German study called the STING study, acronym STING, which stands for Stop Bleeding Study, and enrolling mostly only patients with refractory bleeding. And in this small study, we show a very large difference in favor of the use of the OTSC. Here's a video of a patient with duodenal ulcer rebleeding after the original hemoclips had fallen off. And this is to show you how the OTSC is used. The 19-node clip is in fact housed in a transparent hood, and we can scan the area with the transparent hood with the pull of a string. The OTSC is then deployed. This clip has a superior clip retention rate, and often after many months, the clips in fact remain. And increasingly, we use this OTSC in difficult to manage ulcers, and this is an example of a posterior bulbar ulceration with a pulsatile artery. Here you can see OTSC being used, and you can see the pulsatility to the artery itself. And with a slight suction, bleeding started, and fortunately we successfully deployed the clip, and that the pulsation in fact disappeared, and you can see OTSC successfully deployed over the vessel itself. In the United Kingdom, there's been 2 national audits on the management of acute upper gastrointestinal bleeding in 1993 and year 2007, respectively. The age structure has not changed. We are seeing a slight decrease in the rate of further bleeding and mortality, and importantly, the rate of surgery has declined from about 7% to 2%. I think a third audit is overdue, and in year 2020, at least at the Prince of Wales Hospital, we are seeing a rate of recurrent bleeding approximately of 4% with aggressive endotherapy, selective angiographic embolization, and also exit suppression. In this talk, I hope I've convinced you that we've successfully put away surgeons in the management of acute upper gastrointestinal bleeding. And I apologize, this is a non-surgical talk. And I'd like to once again thank the college and Professor O'Connell for the privilege of delivering this distinguished lecture. Thank you very much.
Professor Lau, thank you for your lecture. As COVID prevents us from travelling, I'm delighted to invite Mr. David Costello, the Consul General of Ireland to Hong Kong and Macau, to present you with the Abraham Colles Medal on my behalf.
Professor Ronan O'Connell, President, Professor Cathal Kelly, Chief Executive, members and friends of the Royal College of Surgeons in Ireland. May you live in interesting times. This is often misattributed as a translation of a traditional Chinese curse. Irrespective of its provenance, this expression has resonated with me in preparing for today's ceremony. Indeed, beyond interesting times, I would describe the past year as unprecedented in my lifetime. So when President O'Connell approached me about the unprecedented step of moving today's ceremony into a virtual format, I was very keen to help our friends in the RCSI mark the occasion in a special way for the recipient. In a year when a prominent descendant of Hong Kong is the Lord Mayor of Dublin, it is particularly fitting that a leading Hong Kong medical mind should deliver the Abraham Colles Lecture, named for a former president of the RCSI who died in 1843. Professor Lau is Professor of Surgery at the Chinese University of Hong Kong and Director of the Endoscopy Centre at the Prince of Wales Hospital. He is also known internationally for his clinical research and has published landmark studies in prestigious medical journals. In addition to being a deserving honour for Professor Lau, today's prestigious award is a continuation of the deep historical ties that bind Ireland and Hong Kong, especially in the field of medicine. In the months prior to the passing of Abraham Colles in 1843, colonial life in Hong Kong was just beginning. Since the 1840s, hundreds of Irish doctors have served in Hong Kong in public and private hospitals. Perhaps the first Irish doctor to come to Hong Kong was Donegal-born Francis Nesbitt Dill. In 1844, he was appointed the second colonial surgeon. Along with another Irish surgeon, George Kingston Barton, he was founder member and second president of the China Medical Chirurgical Society, Hong Kong's first medical association, which happened in 1845. However, perhaps the greatest contribution that the Irish have made in Hong Kong in the field of medicine is that by the Columban nuns. 72 years ago, Sister Mary Aquinas arrived in Hong Kong and was appointed the first medical superintendent of the Ruttenji Sanatorium. One of her closest collaborators who joined her at the time was fellow Columban sister, Gabriel O'Mahony. Together, they pioneered the care of tuberculosis in Hong Kong. So today's lecture continues this great legacy in the Ireland-Hong Kong story of furthering our collective knowledge in the field of medicine. That said, it is with great pleasure, on behalf of Professor Ronan O'Connell, that I present the Abraham Colles Medal to Professor James Lau.
Professor Lau, congratulations and thank you again for your excellent lecture. I'm so sorry that you could not travel to the college. However, I hope that we will have the pleasure of your company when COVID restrictions allow. Your old mentor, Professor Sidney Chung, RCSI graduate and honorary fellow, will be very proud. I hope he will get the opportunity to see your lecture online. I'm very grateful to Mr. David Costello and his colleagues at the Consulate General of Ireland to Hong Kong and Macau for their generous assistance and hospitality this evening, and indeed last night during the award of the Honorary Fellowship to Professor C.M. Lowe. In closing, may I thank all who've participated in what I hope you will agree has been an extraordinary Charter Day evening. Good evening, thank you, and stay safe.